Hello everyone, welcome to our Zoom meeting. Today we're gonna have a couple of topics to talk about, and Dr. Malaz and her team will be presenting. So when you are ready, Dr. Malaz, please go ahead.
Assalamu alaikum and good evening, everyone. First, I would like to sincere appreciation to Dr. Nadir for his continued leadership, guidance, and support, and a very warm welcome to all our fellows. I would especially like to welcome our newly joined fellows. We are delighted to have you as part of TGRF community, and we look forward to your ideas, experiences, and contribution. And even so, I would like to warmly welcome our senior and continuing fellows. Thank you for continuing to share your knowledge, your experience, and support with the fellowship community. And for those who may not know me, I'm Dr. Malaz, and it's my pleasure to serve as the moderator for today's meeting. So today we have three engaging presentations that address three distinct but equally important dimensions of clinical care, managing common chronic conditions, exploring an innovative diagnostic application, and strengthening the physician-patient relationship. So first, Dr. Omer will present on hypertension, a major global health concern and one of the most important modifiable risk factors in clinical practice. And then next, Dr. Nabiha will discuss the use of ultrasound in sleep disorders, introducing us an interesting and evolving areas of diagnostic medicine. And finally, Dr. Alaa will present the art of building trust in the first 5 minutes, how great physicians connect before they diagnose. So following each presentation, we will have time for questions and discussion. So please feel free if you have any questions after the presenters finishes presentations. And even so, if you want to open discussion and so on, you can raise your hand or even so open your mic after that. So we are looking forward to learning from all three presentations and having interactive and valuable discussions. So let's begin with our first presentation. It's my pleasure to invite our first presentation, Dr. Rayyan. Dr. Rayyan, thank you so much for joining us. The floor is yours if you are ready, and if you need any help, let me know.
Thank you so much, Dr. Malaz. Thank you for giving me this opportunity. Thank you also, Dr. Nader. Hello, everyone. Good morning or good evening, based on your time zone. I am Rayyan Badawi, or Rayyan Omer. Today, inshallah, I will talk about the hypertension, as said by Dr. Malaz. So I'm going to share my screen and tell me if everything is clear, okay? Just let me know if you can see my screen and if my voice is clear to you.
Yes, very clear.
Thank you so much. So, hello everyone. Today, inshallah, I'm gonna talk about the hypertension in older adults. As said by Dr. Malaz, it's really a global issue, and it's a very important topic in elderly people. And the prevalence of hypertension is really, really high. We're gonna go through the slides and we can see that. But it's really a very important topic. I used how low should we go? We will see that in the next slide, but put this sentence in your mind. So before starting or jumping to the hypertension, the prevalence, the pathophysiology, the treatment, and when we should treat, I will give you like two scenarios. Put these two scenarios with you because they are really very important and they are considered to be the core of our lecture today. So I have two cases. Case one, we have a robust older adult who is 72 years old man with hypertension and dyslipidemia, fully independent, in activity of daily livings and instrumental, and physically active with intact cognition. There is no history of dizziness, syncope, or falls, or orthostatic symptoms. The office blood pressure is high. It's 158/82. This is when he is seated, when he is sitting down. Standing blood pressure was 154/80. And I'm going to tell you why we are measuring the blood pressure while the patient is standing. His heart rate is good, estimated GFR is good. He is currently taking amlodipine 5 milligram once daily. So this patient is elderly, he is a geriatrics, okay? But you can see he is fully independent in his daily activities, okay? He has no cognitive impairment, no history of dizziness, syncope, falls, or orthostatic symptoms, and his blood pressure is high. That means we need to treat his blood pressure. We will see, just for this moment, we can just focus on these clinical scenarios. The second case is frail older adult. He is 89 years old, female or woman with hypertension, okay, chronic kidney disease, cognitive impairment, and severe frailty, okay, scale is 7, dependent for activity of daily living, okay, and with 3 falls in the previous 6 months. This is a significant history of falling. Her seated blood pressure is 158/82, the same blood pressure as the first case. They have the same blood pressure, but falls to 118/64 on standing with dizziness. So you can see here, those two patients have the same seated blood pressure, okay? But they are completely different from each other. The first case is fully independent, active, cognitively intact, no history of falling, no dizziness, nothing, okay? The second one is frail with many comorbidities with falling blood pressure while standing. Despite that, those two patients have the same blood pressure. Actually, in the treatment of the blood pressure in those patients, we will not use the same method. We will treat them differently, completely. One is good, active, the other is frail. So just put those two cases in your mind. We can move to the next slide. So, hypertension in older adults. Now we can talk about the prevalence. Hypertension prevalence increases markedly with advancing age. That's true. You know, as I mentioned before, I'm working in a home care setting. I'm dealing with geriatrics all the time. All my patients are above 65, 70, 80, 90, like this, okay? So most of my patients have a high blood pressure. They have a hypertension, but it differs from patient to patient. And the treatment of the hypertension also differs from patient to patient. This we call it as individualized treatment. We are treating the patient, not only the number, okay? Because sometimes you need to see the balance between the benefit and the harm from starting antihypertensive medications. So you can see here, hypertension prevalence increases with age, and you can see here, young people will have high blood pressure, the prevalence, 20 in men, 9 in women. From 45 to 59, men will be 57, is still female, subhanallah, 52. But above 60 years old, men and women become close to each other in the term of hypertension, okay? So from 60 years old to 80 years old, actually men and women will have the same or very close percentage. The key point that by age 75 to 80, more than 8 in 10 adults have hypertension. That's why I'm telling you, most of my patients have hypertension. So let's go to the control gap. I want to say something. Based on the latest data, they have found that 71% of adults aged more than 60 years have hypertension. Can you imagine? 71% have a hypertension. 59% with hypertension, they are aware about their condition or their medical condition, okay? 51% they are taking antihypertensive. And guess what? Only 20% they have a control on their blood pressure. So 1 in each 5 patients who are taking the antihypertensive medications, they actually controlling their blood pressure. The rest, they are not controlling their blood pressure. So we have to ask a question. Why does the blood pressure rise with aging? Well, in the pathophysiology, we know that with aging, there will be some differences in our cardiac structure. You know, this is the heart and this is the aorta. You know that the aorta contains elastin, and the elastin give the aorta the ability to expand and to recoil. Guess what? We have the systolic blood pressure and we have the diastolic blood pressure. The systolic blood pressure depends on the ability of the aorta to expand. So when a blood from the left ventricle is ejected, which is the stroke volume, of course, is ejected into the aorta, there should be a space for expanding. If the aorta is not expanding, the pressure will increase, okay? So, subhanAllah, with aging, there is an issue. Elastin in the aorta will be decreased, and this will affect the wall of the aorta itself. It will be very stiff. So we will have an issue with the expanding and the recoiling. That systolic blood pressure depends on the expanding of the aortic wall, and the diastolic blood pressure it depends on the recoil of the aortic wall, okay? I'm just telling you that because I have a clinical note that I want to say it at this point. So if we cannot expand the aorta because of the aging and the stiffness, the systolic blood pressure will be high. And guess what? The blood pressure, the diastolic blood pressure depends on the recoiling of the aorta. If we cannot recoil, the blood pressure actually, it will drop. It will drop a little bit because the stroke volume and the recoil of the aorta was giving the diastolic blood pressure the pressure that actually found. So if we don't have expanding and there is no recoiling, that means the systolic blood pressure will increase and the diastolic blood pressure, it could be normal or it could be dropped a little bit. So it could be normal or dropped. Why I'm saying that? Because in elderly people, you can find something called isolated systolic hypertension. It's something common. I have seen that a lot in my patients. Like in 130 patients, I have seen many of them have isolated systolic hypertension. So you can find the systolic blood pressure is 160 and subhanAllah, the diastolic blood pressure is normal, it's 80. So this commonly happens with age. That's why we are saying that patients, elderly patients could have isolated systolic hypertension with wide pulse pressure. The pulse pressure, it's the difference between the systolic blood pressure and the diastolic blood pressure. Usually it should be 40 or less, right? But in this situation, we can find that 160 over 80, we have a huge number actually. It's like 80%. So, 80 millimeter mercury. So this patient could have isolated systolic hypertension and wide pulse pressure. So why I'm saying that? Because in the treatment, we can find some medication that used for the isolated systolic hypertension. And this is why the elderly people have a common prevalence of isolated systolic hypertension because of the progressive arterial stiffening and reduced vascular compliance, okay? This is number one. So this is very important. And another thing that I want to say, those people have, they have a chance to have a low diastolic blood pressure. So what is the issue? In elderly people and frail people, I'm so afraid of very low diastolic blood pressure. Why? Because you know the coronary arteries that supplying the heart, they are giving the blood to the cardiac muscle during the diastole. So if we have a very low diastolic blood pressure, that will affect the perfusion of the heart, and maybe the perfusion of the heart will decrease. And this, of course, will predispose for ischemia, ischemic heart disease, and sometimes, ischemia, the stable angina and the acute coronary syndrome, the rest of the story. Okay, so this is the first thing. The second thing is that endothelial dysfunction and impaired vasodilation. As adults, we have nitric oxide in our blood vessels, okay, that produced inside our blood vessels or in the endothelium. So elderly people will have a low level of nitric oxide. That means the blood vessels cannot be dilated. The nitric oxide function is to dilate the blood vessels. So if we have a low nitric oxide amount in our blood vessels, that means the blood vessels will be constricted. So the constricted blood vessel could lead to high blood pressure. You know that the blood pressure equation from the physiology, it's equal cardiac output multiplied by the total peripheral resistance, and the total peripheral resistance depends on the arteriole. So if we have severe vasoconstriction or vasoconstriction in the blood vessels, this will increase the blood pressure. We have another thing which is really, really very important, and we can see it in the next slide. Not the next slide, but in one of our slides, reduced baroreflex sensitivity and autonomic dysfunction. This is very important in elderly or in geriatrics. You know why? The aorta itself, it contains the baroreceptors. All of you know that the baroreceptors, that the receptors found in the aortic arch and the carotid sinus. These baroreceptors responsible for detecting the blood pressure. If the blood pressure is low, it will be, the stretching will decrease in the baroreceptors, and it will give a signal to the brainstem. We have the midbrain bones, medulla oblongata. Of course, it will give a signal to the brainstem. So the low blood pressure, we can manage it. The response will be that the brainstem will send the sympathetic nervous system, so it can increase the heart rate, do severe or do vasoconstriction, so we can elevate the blood pressure, and vice versa. If the blood pressure was high, the baroreceptors also can work, and it can activate the brainstem to activate the parasympathetic and inhibit the sympathetic, so we can decrease the blood pressure. It will cause vasodilation and decrease in heart rate. Anyways, what I want to say that in elderly people, subhanallah, their baroreflex or the baroreceptors are not working anymore. By aging itself, as we mentioned here, and by other comorbidities in elderly people. You can find them have diabetes, Parkinsonism, and other medical conditions that already can affect the autonomic nervous system. But aging itself is one of the causes of the autonomic system or autonomic nervous system dysfunction. So why this is important? You know why? Because blood pressure when we are sitting, it differs from when we are standing. So an adult, a normal adult, not elderly or frail geriatrics patient. I'm talking about a normal adult. When he is sitting and suddenly he stands, his baroreceptors will act to increase the blood pressure, because when he is standing up, the blood will be pooling in the lower limbs, and we need the baroreceptors to do the vasoconstriction, to help in the vasoconstriction and elevation of the blood pressure. In elderly people, subhanAllah, they lose this ability. So that's why in elderly people, when we are trying to measure the blood pressure, we are measuring the blood pressure while they are sitting down and while they are standing, because some of them will lose their ability to control the blood pressure through the baroreceptors because of the dysfunction of that. That's very important, because when you need to treat the patient who has a hypertension, you should think about the orthostatic hypotension. You need to put this in your consideration before starting the antihypertensive medications, okay? We have another thing, which is age-related renal changes, sodium retention, and increased salt sensitivity. SubhanAllah, in elderly people, their kidney will be very sensitive. It has the ability to reabsorb the sodium easily and water. So the extravascular volume will increase, and this will increase the blood pressure to some extent, okay? So the isolated systolic hypertension plus widened pulse pressure, it could be associated with aging process, as I mentioned, due to the changes in the aortic or in the aorta, or the muscle of the aorta and the stiffness and all these things. Okay, so let's move to the next. The next is blood pressure assessment in older adults. So the assessment of blood pressure in older adults, just let me to do this, okay? Before treating the number, make sure the number is real. What I'm trying to say is that the hypertension itself in the elderly people, if you want to treat it, you should make sure that the number is true, okay? Standardized office blood pressure measurement, appropriate cuff, correct positioning, repeated measurements. Of course, each patient should have the appropriate cuff, and you should put the monitor in a correct way. This is known, of course. Measure sitting and standing blood pressure. That's what I'm talking about. Because patients with high blood pressure while they are sitting, and a dropped blood pressure during standing, which we call it orthostatic hypotension, and we will see it in one of the slides when the systolic blood pressure is decreased by more than 20 millimeter mercury, and the diastolic decrease. the systolic decreased by more than 20 millimeter mercury, and the diastolic decreased by more than 10 millimeter mercury. This we will call it orthostatic hypotension. In patients with high blood pressure while sitting and dropped pressure or orthostatic hypotension while they are standing, the treatment of the hypertension, you should be careful while treating that, and you will see if this orthostatic hypotension is symptomatic or not. Like the patients have dizziness, fall history, syncope, anything related to the low blood pressure. So particularly with frailty, dizziness, falls, diabetes, Parkinsonism, or treatment intensification, because people with diabetes and Parkinsonism could have complications like autonomic dysfunction, and this will lead to the affection of the baroreceptors, of course, and then the orthostatic hypotension. Use the home blood pressure monitoring or ambulatory blood pressure monitoring to confirm hypertension and identify white coat, masked, and nocturnal hypertension. The home blood pressure monitoring is good because you will measure the blood pressure outside the clinic, okay? And the patient will be rested, so you can avoid the white coat hypertension. You will measure daily at different times, but actually the ambulatory blood pressure monitoring is better because you are putting a monitor on the patient during the day, 24 hours, and this can detect the blood pressure during night and during the day, and at which time that the blood pressure is peak and the mean of the blood pressure. So whatever, we should use the appropriate method to confirm the correct number for the blood pressure. Assess for orthostatic hypotension and blood pressure variability before intensifying antihypertensive therapy. What does that mean? It means if we have a patient with high blood pressure and he has been already taking or using antihypertensive medications, okay, and we have found that the patient has a high blood pressure while he is sitting, we should be careful about that. So we will measure the blood pressure while he's standing. So if we had an orthostatic hypotension, that could be symptomatic with falling, with syncope, with dizziness. Actually, at this time, maybe you will think to review the medications, and rather than intensifying that treatment, maybe you will de-prescribe, because treating the hypertension and ignoring the falls, the syncope, the dizziness, this is considered to be like focusing on the harm more than the benefit of the patient. Review the medications, volume status, and comorbidities that may alter blood pressure or increase treatment-related risk. Okay, let's move to the next. So when should we treat, right? Are you with me, everyone? Is it clear till now?
Yes.
Thank you, Doctor.
Yes.
Thank you so much. So very good. Let's go to the next slide. I'm gonna just delete what I have done so you can see clearly. So when should we treat? Look at this carefully. The treatment threshold. The blood pressure, when the blood pressure is more than 140/90, the pharmacological treatment is recommended, regardless of the cardiovascular risk. So if it's more than 140/90, you should treat, regardless of anything else. You know, the hypertension considered to be a modifiable risk factor for many complications, one of them the stroke. So when we treat and control the blood pressure, it will help us to prevent the stroke, the heart failure, the ischemic heart disease, okay? So if it's more than 140/90, you should treat, regardless of the cardiovascular risk. If the blood pressure is more than 130/80, it means like from 130 to 139. And this is the systole, the diastole from 80 to 89. So if we have, this is considered to be stage 1, okay? 140/90, it is stage 2. This you should treat immediately. But stage 1, like the blood pressure more than or equal to 130/80, but the patient has cardiovascular disease, diabetes, chronic kidney disease, or prevent 10-year cardiovascular risk 7.5 or more, we should start the pharmacological treatment. So stage 1 hypertension, we will not immediately give medications unless there is other comorbidities, like the cardiovascular, the diabetes, the chronic kidney disease, or the cardiovascular risk, or the PREVENT. The PREVENT is the predicting risk of cardiovascular disease events. You will calculate the cardiovascular risk for this patient, and if it was more than 7.5, we can start the medical treatment or the pharmacological treatment for the hypertension. So stage 1, either to be associated with chronic morbidities or the cardiovascular risk more than 7.5 or equal to it. Even if it was the first stage, we will give the medications. But in this first stage, if we have a low cardiovascular risk, low than 7.5, and there is no other comorbidities, so we can start with lifestyle intervention for 3 to 6 months. Then medication if blood pressure remains elevated. So 130/80 till 139 to 89. Actually, we will start the medications if we had another comorbidities, okay? And if the cardiovascular risk was more than 7.5. And if we have no other comorbidities and we have a low cardiovascular disease risk, less than 7.5%, we will not start the medications immediately. Instead, we will change the lifestyle. We will do a lifestyle intervention and wait the patient for 6 months. And if the blood pressure remained high, we will start the medications. And we have patients who are more than 80 years, adults who are more than 80 years. The treatment at more than 130/80 may be appropriate when expected benefits outweigh harms and treatment aligns with the patient's goals. What I want to give you today, that is elderly people who are 80 years old, who can really benefit from the antihypertensive medications. We should give them this medication. For example, if I have an 80 years old male who is frail, bedridden, with history of a stroke and dementia, okay, and he has a history of dizziness or anything like this, okay, and another 80 years old man who is ambulating, active, cognitively intact, he is doing his activity of daily livings, he can go outside and buy his groceries. This one is very good. And if he had a high blood pressure, it was more than 130/80, for this patient, the active one, they have the same age, but the active one, I will give him the medications, okay, because he can get benefit from this medication. This is the term that's called individualized. We are treating the patient, not the number, not only the high number of the systolic blood pressure or the diastolic blood pressure, okay? We can move to the next slide. For everyone. So look to this one, the blood pressure targets in geriatrics. So the general target will be blood pressure less than 130/80 if tolerated. Okay, because if patient developed severe hypotension, syncope, falls, dizziness after starting the medications, we should stop that or de-prescribe or try to lower the antihypertensive medication. But the general target will be less than 130/80. Robust, independent older adults treat according to standard blood pressure targets. Age alone is not a reason for less intensive treatment. What I'm trying to say is that the elderly male who is 80 years old, but mashallah, he's very fit and he has a high blood pressure, this patient, we can give him antihypertensive medication and we can intensify the medications in order to have a controlled blood pressure so we can prevent the complications from the high blood pressure, like the stroke, the heart failure, and the ischemic heart disease. Frail or vulnerable older adults, individualize the blood pressure target according to frailty, functional status, comorbidities, and treatment tolerance. This is what I'm trying to say. 80 years old male, but bedridden with dementia, stroke, and other comorbidities. we are trying to give him the antihypertensive medication to control the blood pressure. But if the antihypertensive medications could lead to other complications, to any current complications, we will try to treat the patient based on his clinical status, not just aggressively to control the blood pressure. Consider a less intensive approach with symptomatic orthostatic hypotension. Of course, if a patient has a high blood pressure, the elderly patient who has a high blood pressure, and then unfortunately he has a symptomatic orthostatic hypotension, recurrent falls, syncope, severe frailty, so institutionalization or limited life expectancy. They are talking about the patients who are sitting in nursing home care, or patients who have a limited life expectancy. Those patients will try to manage the hypertension in a less aggressive way. So to prevent the harm that could occur from the reducing the blood pressure in an aggressive way. So monitor standing blood pressure, symptoms, renal function, electrolytes, and adverse effects during treatment, definitely. We will see the medications that have been used to treat the hypertension, and you will understand that those medications we should monitor for their side effects. So the renal function, electrolytes, adverse effects during treatment, it's one of the most important things that we should monitor the patient because of it. And this will tell us the patient is tolerable to these medications or not. Use clinical judgment and shared decision-making when the risk of intensive blood pressure lowering may outweigh cardiovascular benefit. Why you are controlling the blood pressure? The main reason from controlling the blood pressure is to prevent the cardiovascular complications. Of course, the stroke is very important, then the heart failure and the ischemic heart disease and the cardiovascular complications. So we are trying to control the blood pressure just to prevent the complication from the high blood pressure. We can move to the next. The pharmacological treatment for the hypertension. See here, we have the first line agents. You know, we have the thiazide or the thiazide-like diuretics, like the indapamide and chlorothalidone. In elderly people, we have something called isolated systolic hypertension, as I mentioned for you, right? The thiazide-like diuretics, it can help in the isolated systemic hypertension. Long-acting dihydropyridine calcium channel blockers like the amlodipine also, it's helpful in the treatment of isolated systolic hypertension. We have the angiotensin converting enzyme inhibitors, particularly when we have renal cardiovascular indications that existed, because the ACE inhibitors will affect the kidney, of course, and it can prevent the cardiac remodeling. So ACE inhibitors could be used to treat the hypertension if we had renal or cardiovascular indication. The angiotensin receptor blockers, it works in a different way, it blocks the receptor, but we use it usually as alternatives when the ACE inhibitors is not tolerated by the patient, like the patient has cough and he cannot continue on ACE inhibitors, so we can switch on ARABs. So when ACE inhibitors are not tolerated, we have the beta blockers. Actually, it's not a routine first-line therapy for uncomplicated hypertension, but we can use it when there is really an indication. I have found something different here in Saudi Arabia, because all my patients who are geriatrics, all of them above 65 years old, I have found that those patients, they are taking beta blockers. And we know that the beta blockers are not the first line now, based on the guidelines, the current guidelines. The beta blockers is not the first line treatment for hypertension, unless we have something else that we need the beta blockers to be with it, to be combined with it. But subhanAllah, here in Saudi Arabia, most of the patients previously, they were taking the beta blockers 20 years ago, and they were attached to their medication, so they don't want to change it now. That's something I have noticed here in Saudi Arabia, but beta blockers is not a first-line treatment recently for the hypertension, okay? Let's move. Choosing the right drug in older adults. Well, this slide is important, actually. We can go through it. The isolated systolic hypertension, as I told you before in the slide of the pathophysiology, the best choice for the treatment is the long-acting calcium channel blockers or thiazide-like diuretics. If we have a chronic of course, we are talking about patients who have hypertension with those other conditions. Isolated systolic hypertension, okay, we will treat with the calcium channel blockers or thiazide-like diuretics. Chronic kidney disease with albuminuria. If we have a hypertension with chronic kidney disease and albuminuria, we can use ACE inhibitors or ARBs because it can decrease the albuminuria. It acts on the glomeruli, the efferent of the glomeruli, so it can decrease the albuminuria and decrease the progression of the chronic kidney disease. If we have a coronary artery disease and previous myocardial infarction, and the patient has a hypertension, because we said already the hypertension predisposed for the ischemic heart to the ischemic heart disease. So beta blockers plus ACE inhibitors and ARBs, it could be very beneficial because it can change the remodeling of the cardiac muscle. So it can help the muscle of the heart to be stabilized. If we have a hypertension with heart failure, we will use the guideline-directed heart failure therapy. Of course, you know that the heart failure, we will have the heart failure with reduced ejection fraction and with preserved ejection fraction. Anyways, heart failure with hypertension, there is some medication that considered to decrease the mortality in heart failure, like the beta blockers, ACE inhibitors, ARBs, the spironolactone, which is the mineralocorticoid receptor antagonist. Anyways, all these medications that's used for the heart failure, it can use in the hypertension, and it's very beneficial in patients with heart failure. So heart failure with hypertension, we can use ACE inhibitors, ARBs, beta blockers, because they can decrease the mortality and morbidity in heart failure. Peripheral edema. Be cautious with dihydropyridine. He's talking about the calcium channel blockers like the amlodipine. The amlodipine causes vasodilation, so it can lead to peripheral edema. So you should notice that, okay? Because some people will develop the peripheral edema because they are taking amlodipine, which is very common to be prescribed for the patients, and some of them will need you will need to add like ACE inhibitors to counteract the vasodilation effect on the blood vessels, so you can control the edema from the amlodipine. Of course, you should check the sodium, hyponatremia, gout, volume depletion. You should be cautious when you are using thiazide diuretics, because one of the most side effects and important side effects for these thiazide-like diuretics is that it causes hyponatremia, and of course it causes hypokalemia, and it could increase the glucose. It can cause hyperglycemia. It can increase the uric acid, and it can cause gout. And of course, due to diuresis and loss of sodium and water in the urine, it will lead to volume depletion. And this is very important in our elderly people, you know, elderly people who are taking antihypertensive medications and they are not controlled on these medications, okay? You should assess the patient status, the volume status particularly, and to review the medications to see if the patient is volume depleted. You cannot give like other medications to decrease the blood pressure. You will try to correct the reversible causes, okay, and to review the medications and to try to see the balance between the benefit and the harm from the additional antihypertensive medications. Also, you should be careful about the hyperkalemia. The ACE inhibitors and ARBs, one of the most important side effects for them is high potassium or the hyperkalemia. So people with advanced renal dysfunction or any chronic renal disease, when you start the ACE inhibitors or ARBs, you should follow with investigations. You should follow the serum creatinine and the potassium level. You should follow it routinely until you can make sure that these new medications did not affect the patient's kidney. Bradycardia, conduction diseases. Yes, if we have a hypertension with bradycardia, conduction disease, of course, we should avoid or be cautious with the beta blockers and calcium channel blockers, but non-dihydropyridine calcium channel blockers like the verapamil and diltiazem, I guess. Those medications could decrease the heart rate. So hypertension with bradycardia, you should avoid these medications. Let's move to the next. Okay. The next slide is about the frail, very old patient. Let's see what is this exactly. So here, consider initial monotherapy in patients equal or more than 85 years old, moderate to severe frailty or symptomatic orthostatic hypotension. Here is telling us about the treatment of the hypertension in severely frail elderly patient. We will start with monotherapy, okay? And we will make sure that if the patient has an orthostatic hypotension, to modify our therapy or our medications as much as we can, so we can balance the harm and the benefit from the medications. We should start with low dose and titrate cautiously according to response and tolerability. If the patient can tolerate the medications, okay, we can start low and go slow. Avoid rapid or excessive blood pressure reduction, of course, particularly in elderly people and frail and geriatrics, because we said before, they have already a problem with the autonomic nervous system and they could have orthostatic hypotension. So we should avoid rapid or excessive blood pressure reduction. Checking or check sitting and standing blood pressure after treatment changes. When you want to replace a medicine by another one, or if you want to add another antihypertensive medications, you should check the blood pressure while sitting and while standing, because the additional medication could affect the standing blood pressure, and this medication was used to control the blood pressure so we can prevent the complication. Instead of that, if we added another antihypertensive medication and it was the main cause for the development of orthostatic hypotension, the patient could develop dizziness, could develop syncope, fall, and the complications of the antihypertensive medication will be harmful for this patient. Monitor renal function, sodium and potassium, of course, because we said ACE inhibitors, ARBs, they are affecting the kidney, sodium, potassium. Actually, it affects the potassium and the renal function, so we should monitor the kidney function test. Regularly reassess dizziness, syncope, falls, cognition, and functional status, because we are not treating a number, we are treating a patient. Okay, so we should focus on the patient, not on the number. If you remember the earlier cases, we have two cases. One of them was frail with high blood pressure, but was frail with comorbidities and orthostatic hypotension. For this patient, if I added more antihypertensive medication, I will increase the orthostatic hypotension, and I will give this patient a cause to have a syncope, to have a dizziness, to fall, and to have more complications than the high blood pressure alone. On the other hand, the other case was an active patient, mashallah, independent in all of his activities. This patient really could benefit from the antihypertensive medication. So I'm going to repeat this again. The treatment of hypertension, particularly in elderly frail patients, it's considered to be individualized based on the patient's condition and current status. I'm not going to treat the number only. Avoid medications with high orthostatic CNS burden when possible, like the alpha blockers, central alpha-2 agonists like the clonidine, and the direct vasodilators, unless it was specifically indicated. But in general, we need to avoid it, okay? There is some trials, 3 trials that were very important it's very important, and it's strongly related to the treatment. Actually, it's used for the treatment of the hypertension. So those 3 studies are very important, and I'm gonna tell you those 3 studies, okay? And we can take some message from each one. So the HIVIT study that has been done on 3,845 patients who were 80 years old and more, with systolic blood pressure equal or more than 160. They have 2 groups, of course, the control group or the placebo, and the other group who received the medications, indapamide, which is diuretics, and perindopril, which is ACE inhibitors. They found that, and the target was to decrease their systolic blood pressure less than 150/80. So those people who are more than 80 years old, and 80 years old is a number, this is an elderly patient, 80 years old, okay? So they did that on those patients, and their systolic blood pressure was more than 160, and they gave them medications, ACE inhibitors and indapamide, which is diuretic, and the target was to decrease the blood pressure to be less than 150/80. The result, they found that those patients have a decrease in heart failure with 64%. This is a huge number. This is very huge number. So they found that those patients who are 80 years old, because sometimes you can find an 80 years old and you can say to yourself that this patient is 80 years old or more, like 85, 87, and his blood pressure is 160/80. Why I should treat it? Leave him alone, right? No, the HIVIT study found that patients above 80 years old, when they have been treated with the antihypertensive medications, they had a benefit from this treatment, and the heart failure was decreased by 64%. So this is something significant, okay? Regarding the stroke reduction, 30%, they found that there is a stroke reduction 30%, but primary endpoint not statistically significant, okay? It's not significant, but at least the heart failure was decreased with 64%. This is very huge. So even elderly people who are 80 years old or more than 80 years old could benefit from the antihypertensive medications and could prevent some complication like the heart failure. So treating hypertension remains beneficial even in adults who are more than 80 years old, okay? This is very important. The other thing is that Sprint Senior. I guess all of you have heard about this study. So the Sprint Senior, they included a patient who were 75 years old and more. The population were 2,636. They were ambulatory adults aged more than 75 years. The comparison was systolic blood pressure target less than 120, vice versa 140 millimeter mercury. They found that the people who have been treated with the antihypertensive medication, so their blood pressure was controlled and reduced less than 120, they found that there is a major decrease in a major cardiovascular events with 34%, which is really good. Okay, there was no significant increase in injurious falls. What they mean by that? Those patients, mashallah, they were 75 years old and more, and they have been treated with antihypertensive medications. And subhanallah, one of the side effects of the antihypertensive medications is syncope and fall, right? Orthostatic hypotension and all these things. Subhanallah, those patients who received the antihypertensive medications, there was no significant increase in falls. They were good, alhamdulillah. There was no increase in falls, and they had a major cardiovascular decrease in major cardiovascular events, okay? And important, the participants were community dwelling, not severely frail institutionalized. So this means, this study, we have an issue with what we call it in research, the external validity. The external validity, it means the generalization of the study. If I can say this study could be generalized to all patients, the fit ambulatory patients and the patients who are sitting in a home care setting, or who are very frail, or who have a short life expectancy or something like this. This is the issue here in Sprint Senior. Just they used population or patients who were ambulatory and active. That's why we cannot generalize this result on all elderly people, particularly those who are using like a home care setting or a nurse care setting, or any institution. That's why they are said this is important. We are talking about only community dwelling patients or participant, not the severely frail patients. The key message here from the Sprint Senior is that intensive blood pressure lowering can benefit appropriately in selected older adults. In selected older adults, that means the ambulatory, active, elderly patient. But in frail what we can call it frail and patients on nurse care setting and all these things, maybe it will not be applicable. We cannot generalize this study on them, okay? So this was the message from the sprint senior. We can move to the third one. I hope you're okay till now. We are almost done, by the way. I just want to say or to review a couple of slides and then I will finish, inshallah. I don't want you to feel bothered. Okay, so we have the STEP trial. Actually, it includes elderly patients from 60 to 80 years old, okay? And you can see here, the population were 8,511 from 60 to 80 years. And the comparison was systolic blood pressure target between 110 to less than 130, vice versa, 130 to less than 150. The results, they found that primary cardiovascular outcome 3.5%, vice versa, 4.6%. So people who have been treated with the antihypertensive medications and their systolic blood pressure was between 110 and 130, they had a cardiovascular outcome better than those with high blood pressure or high systolic blood pressure between 130 to less than 150. 26% relative reduction in major cardiovascular events, which is good. Most adverse outcomes were similar. Hypotension occurred more often with intensive treatment. In this study, we have found that those patients have a hypotension. Key message from this trial is that lower systolic blood pressure targets can provide additional cardiovascular protection in selected older adults. Still, the generalizability or the external validity of this study will be like an issue. Most of them will be, the study will use or will be done on healthy or ambulatory, active, elderly people, not the frail or the severely ill elderly patients, okay? But still, the treatment of blood pressure could provide additional cardiovascular protection, but in selected patients, okay? We can move to the next. So what do these trials teach us? Sorry. From these trials, we can see that hypertension should be treated even in very old adults. Age alone is not a reason to withhold therapy. Like a patient who is 8 years old or 85 years old, but mashallah active, ambulatory, and he has a high blood pressure. Here you will intensify to control the blood pressure so you can increase the quality of life for this patient and prevent the complications like stroke, cardiovascular complications, heart failure, and all these things, okay? Robust, independent older adults can benefit from intensive blood pressure control when treatment is well tolerated. Patient 80 years old or more, but he is robust, active, okay, and he has a high blood pressure, he can benefit from the antihypertensive medications if even we intensify it. Trial evidence is the strongest in ambulatory community dwelling older adults. As I told you, all these trials have been done on ambulatory active patients. So we cannot generalize the study on the severely ill or severely frail elderly patients. Evidence is less certain in patients with severe frailty, as I told you, symptomatic orthostatic hypotension, advanced multimorbidity, institutionalization, people who are in nurse care setting, or limited life expectancy. So the evidence is usually in elderly people who are active ambulating, okay? In these patients, blood pressure targets should be individualized according to the benefit, harm, function, and patient's goals. We are talking about the severely frail patients. The treatment will be individualized, not like the elderly patient who is active and ambulating. We have something very important, which is called the orthostatic hypotension. Orthostatic hypotension is very important. The definition of it is the fall in blood pressure more than 20 for the systolic blood pressure and more than 10 in the diastolic blood pressure. After standing, actually, when the patient is lying down, and when he was lying down and then sitting, we can measure the orthostatic hypotension or the blood pressure. Or while he was sitting and he's standing after that, he can stand for 1, 2, or 3 minutes. Then we can measure the blood pressure. So measure the blood pressure after 1 or 3 minutes of standing, preferably from supine to standing. This is the preferable one. Particularly important in older adults with frailty, dizziness or syncope, recurrent falls, Parkinsonism and autonomic dysfunction, and polypharmacy. I have seen the orthostatic hypotension a lot in my patients due to different reasons. One of them was due to the medications, because elderly people or elderly males will have hypertension. They could be taking antihypertensive medications, and also elderly people will have benign prostatic hyperplasia, and there is some medication that have been taken for the benign prostatic hyperplasia. It could affect the blood pressure, which is alpha-zocine. So I can find a polypharmacy. I will have many medications that was considered to be the main cause for the orthostatic hypotension for my patients. So we are trying to de-prescribe the medications based on the current status for the patient. So the polypharmacy is very important because it could be a reason for the orthostatic hypotension, and if you manage it and de-prescribe the harmful medications, it could help to prevent the dizziness, syncope, fall, and other complications from the orthostatic hypotension. I have seen also patients. I have 2 or 3 patients with Parkinsonism. They have the orthostatic hypotension. Okay, and dizziness or syncope, frailty. Yes, some people could have problem, like they could have some diuretics, and diuretics will lead to dehydration with other anti-hypertensive medications. This could increase the risk of the orthostatic hypotension. So anyways, particularly important in older adults with this condition. Okay, so frailty, dizziness, syncope, recurrent falls, Parkinsonism, and polypharmacy. We should be very careful and assess for the orthostatic hypotension. So if the patient has an orthostatic hypotension, we will stop the medication immediately. Actually, no. Do not automatically stop antihypertensive therapy when orthostatic hypotension is detected, okay? First, we should assess the symptoms, because some people or some patients could have an orthostatic hypotension, but they are asymptomatic. If the patient is asymptomatic, like I did the blood pressure while he was sitting and then while he was standing, and I found that he has an orthostatic hypotension, but he's asymptomatic. There was no dizziness, no syncope, no fall, nothing. He was very good. I should not change anything at this time because he is asymptomatic. So we should assess for symptoms, volume status, medications, and reversible causes, and standing blood pressure. Okay, so in case of orthostatic hypertension, I should search for the other causes that could be the main cause for the orthostatic hypotension before starting to de-prescribe the antihypertensive medications. So symptomatic or severe orthostatic hypotension, it requires individualized blood pressure targets and treatment adjustment. This is very important. As I told you, we are treating the patient, not the number. We are treating the current status of the patient, his comorbidities. We are looking to the patient as a patient, okay? Not only a number of blood pressure that I want to reduce. So the key message is treat hypertension, but always ask what happens when the patient stands, okay? All the time check, particularly in elderly people. We should check that. We are doing that in the home care setting. When we are visiting the patients at home, we are doing the blood pressure while they are sitting and while they are standing. This is very important. So when should we consider de-prescribing? They are talking about at which situation we should stop the antihypertensive medications or decrease the antihypertensive medications. If we have a progressive or severe frailty, if we have a symptomatic hypotension, orthostatic hypotension, if there was a recurrent falls or syncope, if we have a persistently low blood pressure, if we have a polypharmacy, we can decrease some medications if we found it to be the main cause for the orthostatic hypotension, declining renal function or medication-related adverse effects, limited life expectancy, changing goals of care, all of these causes could be valid for the de-prescribing or decreasing the number of the antihypertensive medications. I feel like there's something I forget or not. I did not mention the non-pharmacological management, right? I feel that there is something missed. So just I will go through it because I have finished already. Just there is some non-pharmacological treatment for the hypertension. You can see here we have the DASH style diet, fruits, vegetables, whole grains, and low-fat dairy. Sodium restriction, because we said elderly people have a very sensitive kidneys. They can reabsorb sodium and water easily, so it will lead to high blood pressure. So we will try to restrict the sodium. We need to do regular physical activity. Weight reduction is very important in patients because it helps in a reduction of the blood pressure. Adequate dietary potassium, unless limited by chronic kidney disease. We should stop alcohol or reduce and avoid alcohol and encourage smoking cessation. In frail older adults, avoid interventions that contribute to dehydration, malnutrition, orthostatic hypotension, or sarcopenia. Because we have elderly people who have a hypertension. I'm doing the clinical dietitian consultation. The nutritionist will go to the patient. If he has a hypertension, she will give him some diet instructions. If he has a diabetes, she will give him some diet instructions, okay? But we should be careful in elderly people that they could have dehydration easily, they could enter in a malnutrition easily. So we should be very careful with that, okay? This is regarding the non-pharmacological management for the high blood pressure treatment, okay? So I almost finished, but I want just to say something. Wait. We have take-home messages. I want you just to get it. It's very important for me. It's like a summary from what we have talked about. Hypertension is extremely common with aging and remains a major modifiable risk factor for stroke, cardiovascular disease, chronic kidney disease, and cognitive decline. It's very important because it's modifiable risk factor. We can control it, so we can prevent the complications. Age alone should never be a reason to undertreat hypertension. Even in elderly people who are more than 80 years old, but you have an 80 years old man who is active ambulating with high blood pressure, you should decrease the blood pressure or control it or intensify the treatment of this blood pressure, because the benefit will be more than the harm of the treatment. For most older adults, aim for blood pressure less than 130/80 when tolerated. Robust, independent older adults may benefit from intensive blood pressure control. That's true, because those studies have been done on ambulatory, robust elderly people. HIVIT, SPRINT, Senior, and STEP studies, all of them support this statement. In frail or vulnerable older adults, consider orthostatic hypotension, falls, functional status, multimorbidity, polypharmacy, institutionalization, and life expectancy. As we mentioned, individualized treatment. We should choose medications according to comorbidities, start cautiously, titrate carefully, and monitor standing blood pressure, renal function, and electrolytes. We are treating the patient, not the number. Okay, deprescribing may be appropriate when treatment-related harm or burden exceeds expected benefit. Okay, those are very important take-home messages that I wanted you to know about it. Let's move to the next. Yes, thank you so much. So thank you, everyone. If you have any question, any comment, anything, you are free. Thank you so much for listening to me for too long. I hope the session was useful for you. Thank you.
Thank you so much, Dr. Rian, for this exceptional presentation. The depth, organization, and the clinical judgment reflected throughout the presentation. This made the effort behind it very clear. So you took us actually from the physiology of the vascular and the accurate blood pressure assessment to treatment, clinical trials, and everything. Thank you so much.
Thank you so much, Dr. Malas. Thank you.
Anyone have any questions?
If there is any question, if there is anything you want to add.
Hello, my name is Safa Hamed. I want to ask one question.
Okay.
So if there is a patient with benign prostatic hypertension and he is old and
Yes.
having, let's say, moderate hypertension, what's the best treatment for him?
You mean he has a high blood pressure,
Yes.
and he has a benign prostatic hyperplasia.
Mhm.
So you want to give a medication for the benign prostatic hyperplasia, but you don't want to reduce the blood pressure, you mean? Or
I want to reduce our blood pressure, and he has benign prostatic hypertension because mostly they're gonna get tamsulosin, which is
yes,
alpha blocker.
yes,
So
tamsulosin is more selective. It can
mhm.
use to treat the benign prostatic hyperplasia, but it has, because it's selective, it has no effect actually, or minimal effect on the blood pressure. But the alpha-zocine, which is used, the trade name is Zartal, it's alpha-zocine. It's used for the treatment of benign prostatic hyperplasia, but actually it causes hypotension. So this medication, alpha-zocine, could be used for the patient who have benign prostatic hyperplasia and hypertension, because it leads to it's not used mainly for the treatment of the hypertension. Like the alpha blockers, like the alpha-zocine or tamsulosin, they are not the main they are not the first line treatment for the hypertension. Okay, the hypertension medications are known: AC inhibitors, ARBs, beta blockers, all these things. Okay, but AC
Mhm.
inhibitors, ARBs, calcium channel blockers, beta blockers, the diuretics, all of these medications are not associated with benign prostatic hyperplasia. So for me, of course, Dr. Nadir could answer, or anyone else could answer. But for me, patient with benign prostatic hyperplasia, he will be treated with antihypertensive medication like anyone else. But what I'm trying to say, if we have two medications, the alpha-zocine and the tamsulosin has a minimal effect on the blood pressure. So it can treat the benign prostatic hyperplasia without dropping the blood pressure. If the patient has a blood pressure and if the patient has a hypertension and he is taking another medication for the blood pressure. So you want to treat the benign prostatic hyperplasia without adding another antihypertensive medication or prostate medication that would lead to decrease in the blood pressure. Okay, so tamsulosin is better because it has no effect or minimal effect on the blood pressure. Alpha-zocine is used for the treatment of benign prostatic hyperplasia, but it can cause hypotension. So as a quick recap, I will let someone else to answer. But what I want to say, if we have a patient with benign prostatic hyperplasia, the treatment of the hypertension will be with the same guidelines. If it was ARBs, AC inhibitors, calcium channel blockers, beta blockers, whatever, he will use any of the other medications for the hypertension that is evidence-based. But for the prostatic hyperplasia, he could use a medication based on his current condition. I don't know if I could, if it's clear or
Yeah,
not.
you answered
Maybe
my
you're asking
question.
another
Thank you so
question.
much.
Thank you so
Yeah,
much,
thank
doctor.
you.
Thank you so much. Okay. So,
Okay, I have question. It was Dr. Rian. Not just for you, it's for Dr. Nadir and anyone else if want to answer. If we look forward to the future and so on, knows that like AI enabled smartwatches, we can say rings, and couple of devices may eventually provide continuous blood pressure estimates and help identify hidden nocturnal hypertension or morning surge and hypotensive episodes. But when we look to older adults with arterial stiffness, atrial fibrillation, tremor, or changing boosters and variable peripheral perfusion, or we're gonna find like inaccurate readings would also trigger unnecessary medication changes and serious harm. So, what geriatric specific validation and safety evidence would you require before trusting these devices to influence treatment? And would you ever, for example, permit an AI system to recommend a medication adjustment? And if that recommendation resulted in hypotension and a fall, where should clinical responsibility lie? It's a very deep, actually, very interesting regarding this. So either you or Dr. Nadir or anyone like as geriatric experience and so on.
Thank you so much, Dr. Melas, for this information, but I feel I couldn't hear you very well. If you're asking a question, I don't know if you're asking a question, but if it's only an information, thank you so much for your additional information, because I couldn't hear you very well.
Okay, I told you that, like now, if we look forward to the future, can you hear me well right now?
Okay, I can hear you, but if you raised your voice, it will be better.
Okay, wait.
I will try to know the question, and if I couldn't answer, I will transfer the question to Dr. Nader. Okay, tell me.
It's
Just
okay. Can you
speak
hear me
slowly,
right now?
Dr. Malaz. Speak slowly. Yeah, go
Okay.
ahead.
Okay, if we look toward the future, we know that AI-enabled smartwatches, rings, and cuffless devices may eventually provide a continuous blood pressure estimate and help us identify hidden nocturnal hypertension or morning surge, we can say, in hypertensive episodes. But when we look to the elder adults with, for example, arterial stiffness or atrial fibrillation or tremor or any changing buttress and variable peripheral perfusion, there may be inaccurate readings could also trigger unnecessary medication changes and serious harm. So, like, as geriatric specific validation and safety evidence, would you require before trusting these devices, to influence treatment? Would you ever permit an AI system to recommend a medication adjustment? And if that recommendation resulted in hypotension and a fall, where should clinical responsibility lie?
Oh, you are asking if I use the AI to
Yeah,
okay. If I used an AI to change or to modify a dose for a patient who is
yes,
elderly and taking antihypertensive medications?
yes.
No, actually, this is very serious. I have a geriatric consultant in my clinical setting, in the home care setting. I have a direct contact with a geriatric consultant. So if I have anything, contact him directly. He's available every day. So, and I'm seeing my patients every day. If there is anything like this, I'm contacting him and he will tell me. He's a geriatrics consultant and he is helping me with that. So no, using only the AI to modify, I feel it's risky. I know the AI could help and it can gather the information and it could be evidence-based information, but of course the AI will lack the clinical experience, particularly for the elderly people and the treatment for the elderly people. And this is a sensitive area. So for me, no. Honestly, I feel afraid using the AI to change a medication for a patient because this could be like a problem for me. If there is any sequence or anything bad happen to the patient, I'll be responsible for that. So no, I did not use the AI to de-prescribe or to prescribe an antihypertensive medications. And alhamdulillah, yes, I have a direct contact with the geriatric consultant who is helping me every day. If I answered your question.
Okay, thank you so much.
Thank you, Dr. Minas. Thank you so much.
Thank you so much, Dr. Ryan, for great presentation and
Thank you, Dr. Nader.
excellent discussion. Thank you so much.
Thank you so much. Thank you, everyone.
Okay, if no one else has any questions, we can move to the next presentation. We're going to be presented by Dr. Nabiha. Dr. Nabiha, are you ready? If you are ready,
Hello,
the floor is
everyone.
yours.
Hello, Dr. Nader. Hello, Dr. Malaz. Yes, I'm ready. Let me just share my screen.
Yes, for Dr. Nabiha.
Okay. All right. So today my topic is ultrasound for sleep disorders, and we are going to talk about a wearable neuromodulation patch, which is basically reshaping the REM sleep research. So as we begin, first of all, let's see that what are the stages of sleep cycle, because understanding this is very important. So for the NREM stage of sleep, there are three stages: stage 1, stage 2, stage 3. And then we come to the last stage, that is the REM sleep, where we have the dreaming. There is brain activity that is high. There is muscle paralysis, and approximately it's of 10 to 60 minutes. And all of the research on with regards to this device was done on the REM sleep. So we'll be focusing on this stage. So let's see what exactly is this device, New Sleep. So this is a soft wearable ultrasound patch that was developed by the researchers at the University of Texas at Austin. The latest research is being done on it, and it is designed to non-invasively influence and monitor the REM sleep overnight. We can see the image over here. And then we need to know that what's novel about it. So first of all, it is soft and wearable. It's not rigid. And then it is non-invasive, so we don't need any medication. We don't need any surgery. It is an externally used implant that is quite effective. And then it works in a closed loop system. So it means that it not only senses the brain activity via EEG, it also adjusts the stimulation in real time. And then it targets the REM sleep. It means that there's focused ultrasound waves that reach the subthalamic nucleus to support the REM related brain regions. So that makes it novel, that it's not only sensing, it's also stimulating and directly affecting the REM sleep. So now we see how it works. So the hydrogel electrodes here read the brain activity, while a concentric ultrasound array delivers focused stimulation to the subthalamic nucleus. So the important thing here is EEG electrodes, which detect the brain activity, and then the focused ultrasound wave that target the ultrasound nucleus, and then how it adjusts the stimulation in a closed loop overnight. And here again, we can see how it is attached externally. So the research was done on 28 participants, and what the researchers found out was that this device increased the REM sleep by 16 minutes, and not only that, the participants reached the REM sleep faster. That is 43 minutes faster than those who did not have this implant. And the research was done on both the healthy sleepers and those with sleep difficulties, and benefits were found in both the type of sleepers. And then all the participants found that it was safe. um, in addition to having an effect on um, is the REM sleep coming fast and how long the REM sleep is. It also showed that the stimulation increased the heart rate variability, and that is very important because this heart rate variability is a marker of the body's ability to respond to stress. And then when the brain imaging was done, it revealed that there were changes associated with the emotional processing. So these two are also very important findings that were done, although more work needs to be done on these aspects to learn more about them. A very important um, a very important thing is that one of the researchers specially mentioned that REM sleep is not just about dreaming, it's about emotional reset and stress adaptation. And that is what makes it very important that we focus specifically on the REM sleep, because it's not just about having a better sleep hygiene, it's also about having better emotional well being and a psychological well being. And that is why when we talk about REM disruptions, so these are associated with diseases like depression, anxiety, and post traumatic stress disorder. So, improving REM sleep can also mean that we may find a future treatment therapy for these three psychological pathologies. Now, a way forward to better therapies. So, as we know that this is a new novel discovery that has been made, a device that is being tested. So, it now opens new possibilities for understanding sleep and treating the sleep disorders. Um, for example, chronic insomnia, and then a broader mental health impact. So, now we can have a way towards better therapies for mood regulation, stress management, and other psychological resilience. Um, and now it's a study with only 28 participants. So now future studies are needed, and some of them are also being conducted with larger participant population. And the goal is that they're now trying to evaluate this new sleep device for diseases like chronic insomnia, depression, and post traumatic stress disorder. So these are the references that I used, and any questions if anyone has got.
Thank you so much, Dr.
Thank you so much,
Nabiha.
Dr. Nabiha.
Thank you so
Hello.
Go
much,
ahead.
Dr. Nabiha. Thank you.
Thank you so much, Dr. Nabiha. I literally actually we miss you so much. Okay, and welcome back.
Thank you so
And
much. I
thank
had
you
been very
always.
busy with a lot of personal things and personal stuff going on, but now I'm back, and yes, I'm back to work again.
Yeah. Actually, I miss your efforts. I miss everything. I miss your achievements and so on. But I know that you will gonna make it, inshallah.
Oh,
I'm
inshallah.
waiting for
Thank you.
you, my friend. Thank you so much.
Thank you.
Okay, anyone have any question or want to add anything or to share any experience?
Thank you so much, Dr. Nabiha, for excellent presentation and important topic that's coming in the future. So uh, I want to share with you last month or early this month, we went for a conference and I had the pleasure of meeting one of the oral presenters there. He has a new company and he's focusing on something that's also interesting. I'm going to share with you the screen. So basically, they are trying to create something like a helmet that you can wear, and it can put some target ultrasound guided uh, signals to target certain areas in the brain, so they can, as mentioned here, can target some of the conditions like anxiety, depression, and maybe other conditions. So things are changing nowadays to non-invasive approaches to help patients with mental illness, for example.
Mhm.
So thank you so much for sharing.
Thank you so much. So, like Dr. Nadir, the
Nadir?
helmet. Sorry,
Oh
yes.
yeah, go ahead, Dr. Nabiha. No, go
I
ahead.
just want to ask, like the helmet that they are working on, is it like a very new thing, just like this device that we just talked about?
They're still working on getting this. So the idea, from what I understood, is that they want to use this approach where they want to uh, establish a way of using ultrasound to target certain areas in the brain, and the user will just put the helmet in place, and then turn it on, and it will calculate and find the place where the target in the brain will be identified.
Right.
The method they are trying to use is minimal signaling, which means they're gonna use different signals from different angles. So the one signal going through the brain is not gonna affect as much, but when all these signals from different areas come to one single target, all of them, let's say 100 of them, then they will have a larger effect. And depending on the setting, you can manipulate the target area in the brain with all these signals coming through at the same time. So they are trying to make it like user friendly, so it's gonna be marketed and accepted in the so
Right.
they are targeting certain diseases and so on. So something coming in the future, it seems. Thank you.
Thank you so much. Also, there is a question like, is there any side effect of neurosleep, the device we just talked about? So the participants which tested the device said that it is safe. So for now, there are no side effects reported. Someone just asked the question, so I just replied.
Thank you so much.
No problem. Thank you.
Dr. Nadir, okay, is it like the goal it should be to maximize the REM sleep or to restore each patient's individual health sleep architecture? Or like even so, how the outcome is gonna be would prove success? Like, is it, for example, the additional REM minutes or the improved emotional regulation? I don't know.
So maybe Dr. Nabiha, you want to answer or elaborate maybe?
Dr. Malas, can you please repeat your question? I did not fully understand.
So, like, is it the goal actually is to maximize REM sleep or to restore each patient's individual health sleep architecture?
Oh, yes. That's actually a very good question. So, according to the researchers, REM sleep
Mm-hmm.
is basically there to regulate our emotions and to give us the peace after all the stress that we have throughout the day. So the goal is to number one, fasten the REM sleep in the cycle, and number two, yes, to increase the duration of the REM sleep so that better mood regulation, better emotional regulation, better adaptation towards stress regulation. Yes.
Okay, so they will gain the outcome would prove success through the REM minutes and improve emotional regulations, better memory, and so on. And
Absolutely,
improve
absolutely.
daytime functioning and so on. Okay, thank you so much.
Absolutely. So the researchers were like, it's not only a treatment for chronic
Mm-hmm.
insomnia, it's also a
Okay,
treatment
great.
for a lot of psychological pathologies, a lot of stress problems, a lot of mood regulations that we need. So it'll be basically a treatment for a lot of things that are associated with the REM sleep.
Mm-hmm. Mm-hmm. Okay, that is great actually. Thank you so much, Dr. Nabiha.
No problem. Thank you so much, Dr.
So I'm
Malas.
gonna share this graph. Basically, the sleep cycle, you can look at it in
Mm-hmm.
a different way. So
Mm-hmm.
the stages that was mentioned, non-REM, 1, 2, 3, 4, and then REM stage here. So as we get into sleep, the first time we have REM, it's gonna be shorter in duration. As we go deep or longer, then the REM sleep stage will elongate or become longer. and so on. And the difference between everyone and the other one will be reduced. So by manipulating with this device, I assume they are trying to extend or prolong the duration, and that will help, as I mentioned, with certain things they target. So hopefully this will be beneficial for the subjects or the patients with these conditions, if that makes sense. Thank you.
Thank you so much, Dr. Nader. Okay, if uh, not any more question, we can move to our last presentation. Dr. Alaa, can you hear me?
Yes, I can. Okay, let
Okay,
me
if you're
set
ready,
up.
the floor is yours.
Yes, yes, I'm ready. Let me set up my
Your mic is muted, Dr. Alaa.
So I need someone to confirm if my voice is heard and the screen is seen.
Yes.
Okay. Hello everyone. My name is Alaa. My name is Alaa Salah. And first I want to do a special thank you to Dr. Nader. This is my first presentation with the telegeriatric. Thank you for Dr. Malaz, Dr. Marwa, Dr. Marianne for leading the way for this presentation. Today we're going to talk about a very important topic that unfortunately they do not teach at school, because the clinical side is a very practical, is a very technically sensitive. It depends solely on our technique in order to have a successful outcome. But we kind of, as healthcare providers, sleep on the fact that we need to communicate successfully with the patient. We need to gain their trust so that we can have a successful outcome. So the question is, why do trust matter in geriatrics? We need to understand that trust is very important. And simply the answer is that older patients are complex patients, and therefore they require complex healthcare needs. Because when you're facing an older patient, you're definitely dealing with someone who might be experiencing many things. You're dealing with an elder patient who has a repeated hospital admissions, who have multiple diagnoses, who have polypharmacy, which is having more than 5 medication at once, which is a lot. You can also dealing with someone who lost their independence, or they're being spoken to through their caregiver instead of them directly. Maybe they're dealing with hearing or vision difficulties, cognitive impairment, uh, feeling that healthcare professionals are rushing them, which is something that we are guilty for. We sometimes rush things because we know that the clinical environment is so hectic. So the patient decides whether they trust the physician within the first few minutes, well before any diagnosis is discussed. With older adults, that decision often comes down to just one silent question, which is a very important question that the patient asks themselves. Am I being treated as a person or simply as an old patient with many problems? And you need to during gaining that trust, you need to understand 3 elements during that process. Uh, the first element is adherence. You have to know that patients follow treatment plans that they trust. So you always need to adhere to the guidelines. You always need to adhere to the rules and to the standards. of your healthcare system. The second element is satisfaction. You also need to understand that trust always drives a positive outcome, hence satisfaction. Also, the third element is malpractice risk. With low trust, there's always complaint. With low trust, there's always fiasco in the clinical environment. So a typical doctor would ask a question like this. So what's wrong with your mother? So you're basically some healthcare providers, they're basically directing the questions to the caregiver or to the co-patients, forgetting that the patient is just sitting there silently. What you should be doing as a healthcare providers is just addressing to the patients, saying something along the lines of, "Good morning, Mrs. X. I'm Dr. Y. I would like to hear from you first. What has been troubling you?" So this small gesture preserve the older person's identity, autonomy, and the patient voice. So by the end, I really want people to understand these important points, mastering the patient-centered interview, which is very important. You really need to put the patient at the focal point. The second point is building rapport quickly, handling emotional patients, delivering bad news very compassionately, addressing cultural differences and health literacy. So, mastering the patient-centered interview. What do we mean by that? It's basically making the patient or the older patient the central person in the consultation. Even when the caregiver is present, you need to always explore more than just the immediate complaint. You need to ask questions. And when you are directing that questions needs to be directed towards the patients. For instance, when you're questioning about the disease and the symptoms itself, you're asking something along the lines of, what symptoms are you experiencing? Because no one will know the full experiences more than the patient themselves, right? When you're asking about the functions, how has this affected dressing, cooking, walking, or bathing? Again, it's all about experiences. So the caregiver might give you their perspectives, but the real experience, you will take it from the patients themselves. When you're asking for a cognition, for instance, how have you noticed changes in memory or thinking? When it comes to mood, you need to ask about their emotional or their emotional status directly. Social situation, who is at home with you? So you always need to just address that question to the patient themselves. The last one is so important, patient priorities, and asking them what matters most for you to keep going. This is particularly very powerful because for a doctor, this the whole situation, the treatment plan may aim to just control blood pressure, for instance, but the patient wants something else. The patient might want to walk to the mosque or to stay independent, to look for their grandchildren, to look for their pets. Whatever their goal is, we need to always see that and try to be able to explore that. A good geriatrician always connect the treatment to what actually the patient wants and value during this process. The second thing is building rapport. And I said without rushing because it's so important, because we're not in a marathon, we're not in a race. You know, you always need to build things slowly and steadily. And rushing through this and just to save time can cost you a very significant information, a very important information. And during this process, you need to put into consideration that you're dealing, as I mentioned, with a complex kind of patients. You're dealing with a patient who might be experiencing a lot of things. For instance, hearing impairment. They might be facing hearing issues, slower speech, which is something very common in elderly patients. Also, cognitive impairment, difficulty finding the words, multiple concerns. It's something that we are seeing with older adults a lot. They would have, in one sentence, they would have 5, 6 concerns at the same time. And the last thing is anxiety. So in the clinic, what you shouldn't be doing is using infantilizing language, which is like baby language. Sentence along the lines of "good girl, sweetie, let's get you sorted." All of these baby language, even though it's sometimes made with good intentions, but it can really undermine the patient's dignity. What you should be doing is using very respectful and pacing and clear language, uh, pausing whenever possible. Let the patient finish. Do not interrupt them, and do not mistaken a slow response for confusion. Use their name always, and use the most important thing is to use adult language because you are dealing with an adult. Don't forget that. The second part is handling emotional patients, which is also something we are seeing a lot. An older patient who seems difficult, quote unquote, may actually be frightened. In emotion in geriatric care are often tied to loss, not just personality. So sometimes this anger or this difficulty that you're seeing, it sometimes is a reflection of other sources or a reflection of other distresses. For instance, bereavement, losing someone, losing a beloved one is something that is can be manifested as anger. Also, loneliness, which is also a pandemic that we, even younger people, are sometimes dealing with. Loss of independence, chronic pain, disability, fear of hospitalization, fear of dementia, fear of death. All of these things can be present in just one person, by the way. So it can be manifested as anger, or it can be manifested as seemingly a difficult patient. So in the clinic, a patient might say something like that. I don't want to go to the hospital again. Every time I go there, I come out worse. So what you should be doing, what you shouldn't be doing is shutting down the conversation by saying, oh, you have to go, it's necessary. Even though it's true to an extent, but you always need to open up the conversation a bit more by feeling them. You should say something along the lines of, it sounds like you had some difficult experiences in the hospital. Can you tell me what happened? So you're exploring their anger, you're exploring the concerns, and this might uncover any significant issue, or it might uncover the justification behind this anger or resistance. So the next objectives is delivering bad news compassionately. Bad news often tied to cancer, dementia, loss of driving privileges, declining mobility, or a need for residential care. Here we need to be careful for ageism. Do not assume just because someone is elderly that they do not they do not want detailed information. That assumption is a form of ageism. Older age does not remove a person's right to know, decide, or participate in their care. What you need to do is you always need to ask questions. Always explore what they're dealing with. In this case, you need to explore whether they are ready to receive a bad news or not. So you should ask something like, how much would you like me to explain what we have found? So you always need to be steady and take things slowly when it comes to that. The last one is cultural differences and health literacy. This is so important because older adults may carry strong cultural expectations about family involvement, also about the authority of doctors and who should receive the medical information. This expectation, as I mentioned, can involve um, family involvement, authority doctors, traditional also medicine. Some in a traditional approach, some would be very embracing for the traditional medicine, some are not. Same with the decision making, the discussing of terminal illness, and who receive the information. In the clinic, the family might say something like that. Doctor, do not tell my mother that she has cancer. So you need to always explore and establish a connection with the patient privately. You need to always ask whether this is okay with them or not, because some patients are very okay with you sharing information about them. They're very okay with you breaking kind of like the confidentiality, because it may sound like breaking the confidentiality, but to some culture it is not. Some people are very 100% embracing for their family to just know about their condition, about their personal information. So what you need to do is to ask the patient that question. When we discuss your health, how would you like your family to be involved? And at this, of course, respect the cultural values, patient autonomy, and also the patient privacy, that rather than just assuming that what the patient wants. So these are key communication skills that we as healthcare providers should learn. The first one is to make a good first impression, active listening, body language, nonverbal communication, shared learning, motivation, interviewing, managing difficult conversations, and we need to also distinguish um, definition between empathy and sympathy, which is something that can be very confusing at some time. So first impression and active listening. For first impression, for an older patient, your first impression should always tackle, I see you, I hear you, and I respect you. So you first need to greet the patient first, introduce yourself, sit at their level, face them when you speak, make sure they can hear you. Do not shout automatically. Do not assume impairment is a form of a slower response. And always remember, never speak. Always remember. I'm sorry, can you mute the mic, please? Okay. You need to always remember to never speak to the caregiver as if the patient is not there. We should always deal with the patient as if they are adults, they have full capacity to their decision and to the medical information. The second thing is active listening, this is something that customer service representatives are using. They always trying to absorb so many information at the same time. And this is exactly what happens with elderly patients, as we mentioned before, that they may have multiple concerns at the same time. So let's see this concern. This is a patient, he might be saying, Doctor, my knees hurts. I've been falling. I haven't been sleeping. I'm worrying about memory. My daughter thinks that I shouldn't live alone, which is a lot of things, a list of things. You need to all absorb them and acknowledge them, even if you're thinking that there's a much important one, you need to always absorb this information and acknowledge this information, summarize what you have listened, and then ask the question, which of these is most important for us to address today? Because it's unrealistic if you are trying to just address the whole issues at the same time. So you always need to prioritize when it comes to having multiple concerns or complaints at the same time. So with the body language, you need to understand that every patient has its sensory needs. So for patients with hearing impairment, you should not shout from across the room. You need to face them directly and speak clearly. With mobility impairment, do not just stand over them. You need to sit down at their eye level. With vision impairment, do not just assume they saw you or saw what you did or saw the gesture or the document that you are showing them. You need to say things very clearly, like I am placing this prescription on the table in front of you. So this is very clear. You're involving them in the communication process. So with empathy and sympathy, sympathy is saying something like, oh, that's sad. You are all alone. This is basically pitying the patient or pitying the other person. But with empathy, you say something like, it sounds like I'm being alone. It sounds like being alone has been very difficult since your wife died. It's like recognizing the emotion, understanding beyond just pityness. You are with them. You are literally in their shoes. So we always need to adopt empathy in our communication or in the first encounter with patients. So what you need to also avoid is using the word at your age. It's normal because sometimes pain, there's depression, there's memory problems, there's functional decline. You should not always tie things to just being old and to be an elderly patient. There are many things and many factors that sometimes makes a patient experiencing what they are experiencing. So nonverbal communication and shared decision making. With older adults, nonverbal communication can become particularly important because sensory impairment may affect how communication is interpreted. So you always here need to pay attention to your gesture and to how you communicate without words. A patient with hearing impairment may read your lower voice as, okay, this doctor does not want to talk to me. Again, you're dealing with a very sensitive and a very complex kind of patients. A patient with visual impairments relies so much on the tonality of your voice, rely so much on the touch when appropriate, of course, rely on the verbal explanation because they have a hearing sensation that works on 100% almost. They also rely on environmental cues. So do not assume that they did not respond, therefore they did not understand. They may be just some kind of like a sensory barrier there, and you might not be witnessing that. This is so important, the shared decision making, uh, because we tend to deal with older patients as if they are lacking for capacity, as if they do not have the capacity to have a decision. And you need to understand that the best medical option is not always the best option for this particular person. So here's this scenario of an 85-year-old patient with several chronic illness, considering an intensive treatment and requiring hospital visits. So the doctor may think that this treatment gives the best clinical outcome for them, but the patient might want to just rest for the rest of their life, and they want to just stay at home. As we mentioned before, they might just want to stay with their grandchildren. They just want to uh, take care of their pets. So what you always need to um, ask here is to explore what matters to you. What are you hoping the treatment allows you to do? What would you do? What would you consider an acceptable burden? So always involve them in the decision making process. We have also a motivational interviewing and managing difficult conversation. Motivational interviewing is used to deal with usually a bad habit, or a habit that someone wants to change, like for instance smoking, um, nutrition, activity, fall prevention, diabetes management, reducing the alcohol use. So here you need to avoid using cliches like, oh, you need to exercise more, even though it's true, but it does not motivate them. You need to use questions like, what activities do you enjoy? Here you are motivating them into exploring what they love, what they like, what do they want to do. If they say, I used to walk every day, but I'm afraid of falling, in this case, um, the bad habit is not just from not wanting to do it, or it's this habit being difficult. It's basically there's some barriers like being afraid. So you always need to address the actual barrier here, um, and ask questions like, what would make you feel safe enough to start walking again? With managing difficult conversations, this is, as we mentioned before, that some patients are being labeled as difficult, but here we need to always ask the question, what is making this interaction, this situation, this encounter difficult? We do not always have to point fingers, because this patient might be feeling pain, they might be confused, and sometimes, let's be honest, sometimes the medical information is just difficult to absorb. Sometimes they're complicated. So in this case, you need to also avoid using jargons and using um, scientific or academic wording. Some patient might be frightened. Some patient might experience delirium, worried about finances, which is something very common. Losing independence. They are afraid of institutions. A lot of patients are having conspiracy theories of being afraid of being institutionalized. Maybe they're experiencing hearing issues and hearing problems. So you do not always jump to the conclusion that this patient is difficult. If the patient says, I'm not taking these tablets anymore, you need to avoid saying you have to take them. You should always explore this difficulty, or quote unquote this resistance, by asking them and exploring their concerns. They might be saying something like, they make me dizzy. I fell twice. In this case, the problem is not from their difficulty. The problem is basically that they have a significant clinical issue that we need to deal with. The last things are goal of care and family meetings. Goal of care is so important, because you're not just simply asking yourself, how can we treating this disease, but what does a good outcome look like for this particular old person? So it needs to be tailored for them. There's no, of course, universally correct answers, because every patient has their own goals. As we mentioned before, some patients want to live long, some patients want to remain independent, some patients want to just stay at home, taking care and be with family. Some patients want to be comfortable and avoid hospitalization. The patient's goals should always guide the treatment plan. Family meeting is also an important element. You need to always pay attention to the fact that family involvement is not control. The patient's wishes stay central, as we mentioned before. It's always should lead the guide and should always lead the treatment plan. What you need to establish in a family meeting, you need to answer these questions and to pay attention to these questions. What does everyone understand? What does the family understand? What are the patient's priorities? What does the patient want? What are the medical options? Because you sometimes would be dealing with patients with financial issues. The caregivers are taking care of the patient, so you always need to sometimes involve the family and understand their perspectives. And finally, what is the agreed plan? And they need to eventually, as we mentioned before, they need to be satisfied. Everyone needs to be satisfied because this is the goal, that the patient should come out from the clinic satisfied. When possible, of course. When cognitive impairment is present, introduce decision-making capacity as its own question, and do not assume dementia automatically means incapacity. Basically, for instance, a dementia has stages. Even dementia is even if the patient is diagnosed with dementia, that does not mean they're incapacitated. They can take full responsibility for the decision. You need to involve them unless it's a late stage dementia. In this case, they do not have full capacity for decision making or for taking a certain treatment plan. So this is a scenario, practical exercise, which always, if you need to master the patient-centered interview and building rapport with patients, you need to involve in a role play with a standardized patient. This is the best thing that we can do, but unfortunately, we cannot do that at the moment. But let's run through this scenario of a 78-year-old man with recurrent falls. His daughter accompanies him. The daughter says, Doctor, he's been falling all the time. He does not listen to me. He refuses to use his walking stick. The patient would say, there is nothing wrong with me. My daughter is exaggerating. So the question is, what should a doctor do in this scenario? A good response always address the patient directly. Even the daughter is present. Even the daughter has um, some kind of an involvement, but you always need to address the patient directly, establishing a rapport with the patient. Let him give his perspective, explore why he is refusing or resisting the treatment, involve the daughter appropriately, avoid labeling him as non-compliant or a difficult person, which is something that very important. So the dialogue should be like that. Mr. Ahmed, I would like to hear from you. Can you tell me what happened during your most recent fall? This is exactly addressing the patient, establishing a report, and let him give you perspective. The second question is, what do you think is causing these falls? It's basically exploring the refusal, resistance, why he's not taking the medication or the treatment in this case was what causing the fall. Because again, the patient is the only one who is experiencing the situation fully. So we need to always go back to him for more information. The last one is, what do you find difficult about using the walking skill, the walking sticks? So this is asking, why are you not using the stick? So this turns the conversation from confrontation into a more real and genuine conversation. A second scenario is about unexpected diagnosis. An 82-year-old woman present for memory problems. Her daughter accompanies her. The daughter says, Doctor, she has dementia. She does not know anything. Again, the principle here is just to deal with the caregiver as an important source of information, but it does not, she does not replace the patient. You need to understand that the caregiver informs, but do not replace the patient. The patient's own voice is there, and we need to always go back to the patients. And instead, you need to ask, Mrs. X, what changes have you noticed in your memory? Because again, the patient is the one who is experiencing dementia and loss of memory. And then maybe you can rely for the daughter for additional information and to take feedback from her. Remember that your message or your geriatric message should revolve around these 5 words: dignity, autonomy, listening, empathy, and partnership. In geriatric medicine, trust begins when the older adult feels that we are not simply treating their age, their diagnosis, or their medications. We are listening to the person behind them. We are listening to the person behind them, and I believe that the first 5 minutes are not simply the time before the diagnosis. They are the beginning of a holistic therapeutic relationship between a doctor and an elderly patient. Thank you, everyone. Thank you for attending this session. And if you have any question, I would be so happy to receive them.
Thank you so much, Dr. Alaa, for this really outstanding and lovely presentation. We remind us that patient-centered communication is not just a soft skill added to clinical care. It's part of the clinical intervention itself. Thank you so much, Wallahi.
Thank you so much for listening, everyone. Thank you, Dr. Nadir. Thank you, my teammates. Thank you for everyone who's attending this session. I'll give you another chance if you have any questions. If you don't, I would be so happy to meet you next Saturday to do great things in the future and to collaborate with a future project that I think it's a common ground for us as healthcare professionals. And I think what we're doing here is a great thing. We are learning from each other. We are not just developing. We are learning from everyone here. Thank you, Dr. Malaz. Thank you, Dr. Nabiha, for your
Thank you,
presentation.
Dr. Alaa.
It was really informative. Thank you, Dr. Nadir, for sharing. Stuff. Thank you so much, everyone. And I hope that you'll find this session very enlightening and informative. I tried to make it light and informative, and I hope that.
Thank you so much, Dr. Alaa.
Yeah.
Thank you. It was very nice.
Thank you.
Yeah, you
Thank you
did.
so much.
I just want to say it will be much better if I can hear this presentation before my step 3.
It's never too late. It's never too late.
Thank you so much for a great presentation again. Thank you all. Thank you, Dr. Alaa, for excellent. Any questions or any thing that you want to share from the audience? Anyone wants to ask question or share their experience? Thanks.
Okay, Dr. Alaa, just when you think, in your presentation, you taught us how to protect the humanity of the patient. But when we think about us as clinicians, how can we protect the humanity for us? For example, in healthcare system, you know that it's shaped by time pressure or heavy workloads and so on, a repeated exposure to fear or suffering and loss, you can say. So how can us as clinicians remain empathetic without developing, you can say, compassion fatigue or emotional exhaustion? So you know that in sustainable empathy, mainly the responsibility of the individual clinicians. So, or thus, for example, the healthcare system also have an ethical responsibility to provide the time, the staffing, and psychological support needed to make human
Yes.
communication possible.
Yes, yes. As I mentioned before in the presentation, it's not about time. It's not about time
Mm-hmm.
management. You can manage
Mm-hmm.
someone in 2 seconds.
Mm-hmm.
That's the thing. You need to always empathize with the patient. Use certain wordings, certain words that is involving them, and you always need to connect with them. This is what customer service representative are doing. They're not having a chat for you for an hour or so. They would have an encounter with you for only minutes and sometimes seconds. But you would notice that in their encounter with you, they would ask you, hey, they would say something like, hey, my name is da 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 da. Can you tell me what's your name? That's building rapport. Is like that friendly professionalism or being friendly with you in a professional way. So they would introduce themselves. They would ask you about your name. They would ask you about your concern. All of these is like building rapport. Some clinicians are using their sense of humor. It's their character. That what makes patients love them. Some that's what I mean. It's not about the time. It's not about uh, how many time you're sitting with the patients. It's about
Mm-hmm.
the wording. It's about the connection that you are experiencing with the patient themselves. So
Mm-hmm.
talk to them as if you are talking with a friend, but professionally.
Mm-hmm.
Yeah.
So, like,
Yeah.
you
I hope
mean,
I hope I hope I
yeah,
answered that question.
yeah, you mean like, if sustainable empathy, like, is something like shared responsibility. So, as clinicians, we must practice compassionate connections with healthy boundaries. While, for example, institutions must create conditions in which that compassion can survive. Like, I'm talking about, for example, um, as clinician, we can develop emotional awareness, right? Or healthy
Yeah.
boundaries and reflect practice and so on, peer support, and the ability to recognize early signs of exhaustion. So, and that healthy professional detachment does not mean caring less, right? It means like we are remaining compassionate and fully present without like carrying every patient's sufferings as one's own, right? So the boundary is crossed when self-protection becomes avoidance, or you can say depersonalization, right? Or seeing the patient as another task. But individual resilience cannot um, compensate, we can say, for chronic and understaffing or overwhelming workloads. So insufficient, for example, consultation time and repeated exposure to distress without an opportunity to process it. So I think healthcare organization must provide reasonable workloads and protected breaks and supportive supervision, like confidential psychological support, I mean. You get me? And
Yes. Yeah.
yeah, and a culture in which we can ask for help is viewed as professional responsibility, not as weakness. You get me? Because I literally suffer from this point.
Yes, yes, I get you. I mean, every healthcare system has its own issue when it comes to health policies. Uh,
Yeah,
but this issue is, I think, in my opinion, it's not about working overload. I think it's about learning a skill. If you learn a skill,
yeah,
if you
yeah,
build a habit of learning a skill, you will be managed to do it in a minimal amount of time. So it's always about learning the skill, and it will come with practice. That's why I mentioned that the best way to practice is to practice with um, standardized patient, a role play. With the role play, you always learn very quickly. So yes, it's always about learning the skill of having empathy with patients, even when the work is load, and it's never
it's
impossible. It's
not.
not. It's never. It can be difficult at the beginning, but it will never be something that is impossible or totally impossible.
Yeah, thank you so much.
Thank you so much. Thank you for that question.
Thank you both. Thank you
Okay,
all. Any updates? Any thing new in your live projects, questions, and new ideas, and maybe
Actually, Dr. Nadir, there
suggestions?
is two great updates. Alhamdulillah, our project of hypertension had been accepted in American Heart Association Hypertension Conference of 2026. Alhamdulillah. Regardless, we submitted it in the late breaking abstract, but oh my God, it was very uh, competition, but Alhamdulillah. Uh, we received the notification of acceptance, and even so, our another project about the military medicine have been also accepted in the International Congress of 46 2026, inshallah. Yeah, alhamdulillah. Just we are remaining for we are waiting for our two remaining projects, I think, for the notification. Inshallah, will gonna be the end of this month, because they even so contacted me, the International Society of Hypertension and the Emirates Society of Internal Medicine. They told me that just the announcement will gonna be delayed to the end of the month, inshallah. So I hope so even so to receive the acceptance. And yeah, alhamdulillah, we submitted the stroke. We submitted the stroke abstract to the to American Heart Association International Stroke Conference. So inshallah, I hope to even so to receive the acceptance.
Congratulations, these are good news. So thank you for sharing. Good job, you and your team or teams. Excellent.
Yeah, thank you so much, Dr. Nadir, for your support.
So I know some of you might be new. So if you have questions, please reach out. And if you are not involved in any research project, please contact your team leaders, or in the big WhatsApp group, see which projects are available. If you have your own ideas, please reach out and we can help build a new research project. You can also build a team. If you don't have an idea, you can join any of the teams. The easy option is to join a team that's working on like a mobile application app, or some of these studies systematic review. Take a small part, and then as you go along, you can take more tasks and be more comfortable with the process. Any
Dr. Nader?
Thank you.
Dr. Nader, I have a few questions actually. So, my first question is regarding the research course initiative. So, for people who are applying for the match this cycle, I wanted to know that like what value would this course add to those applicants? And then because many of us would be applying, so um, can we get some help regarding our personal statement on this forum, and our application, maybe the review of the application and the personal statement, and how can we improve it? Can we have any that kind of help here?
So for the first question, I'm gonna just share with you. So basically, the initiative is to get you to the city program, and you can go and register. The good news, we already bought the package for you guys, so now you can join and select any of the courses. So I assume you can start with a simple one. This has about 9 modules. Some they have 14 or less. For example, this one module. You can start with whatever you think is good for you, but basically the idea is to get the basic of the research. You can do it slowly. You can take one class, one course, and finish it, get the certificate, and you can add that to your CV, your ERAS application. Why it's important? I think most of the residency program will expect you to do some research work, not necessarily the first year, but the second year and third year, by showing them that you know your basics of the research. You joined this telegeriatric research fellowship, that's one thing. But when you get a certificate from a well-known organization like the city program, it's accepted in most, if not all, big institutions, and they consider it for their faculty, their residents and fellows, whoever wants to do any type of research. They have to go through certain courses from city, and usually these institutions will pay for them to get these courses. I did that in my residency, and also I did that when I joined the faculty. And this will show them in your application that you are interested in research, you know your basics, and you already did a big step in this area. You can take as many if you have time. We have listed, I think, 5 big items, and in each there are certain courses or different courses, and each course has different modules. But
I'm
my
sorry, Dr.
advice is to take one. Yes.
Can you show the
Go ahead.
page that you just show? Because I want to see how can I get access to it.
So basically, what you need to do is you need to go to cityprogram.org, and then you will want to become a member. So just as a new account, when you log in, it will ask you about your name, address, something like that, but basically your email, and when you finish, it's like 6 steps asking you about what language you want to use and what basically your interest. So you will finish the registration, and don't use as independent, use as join an institution. So you will add the Combined Research Foundation as an institution. It's going to be the Combined Research Foundation, and it will give you the option of getting a list of courses, so you can view the courses that's available. So in this program we have 5 major areas, but the most basic one is the social behavior about the subjects in research. There are other also behavior courses, or so if you want to look at them, you add a course, and here you will find the now it's 6, so ranging from human subject research, conflict, responsible conduct research, any one of this category you can start with. I suggest start with human subject research, and under that, if you go to next, it will have more in-depth courses. So I suggest taking this, for example, or any one of the other, and when you go next, it will list that in your list of courses, and then you can start the course. It will show you how many modules in the course, and you can do that at your leisure time. You can spend as much, you can finish that in one day if you have a long time to spend, or if you want to take it in a small, short periods, you can take one module and finish it, get the quiz. It's required that you pass with 80% of the quiz. So each module will have a quiz of 1 or 2 up to 5 questions. And if you watch the videos or read the material well, you will pass all these questions easily. It's not a difficult, it's straightforward questions. After you're done, you will get a certificate that you completed this and you passed. You can have this certificate as showing that you already completed this course, and you can add that to your LinkedIn, or you can add it to your ERAS application. Again, it's just one of the things that might be considered highly in the process of reviewing your application. Did I answer your question, Dr. Safa?
Yes, thank you so much.
You're welcome.
Dr. Nadir, this is Rupa. I have a question for you, Dr. Nadir.
Yes.
So, could I mention that I'm a part of, I'm a member of the TGRF group and in my ERAS application?
Yes.
Okay.
Yes. It's highly recommended to add that. And one of the things that in the interviews, they ask you about this telegeriatric research fellowship and what you did, what you learned. And most of the time, in the past, we were talking about projects. So what kind of research project, what your task, how was that helping you and successfully? Like, for example, Melas can talk about one of the posters that accepted in the
Yes, sir.
American Heart Association, something like that. But also
Yes.
you can talk about mobile application if you are involved in a mobile application, what
Yes,
kind
sir.
of task and so on. Yes.
Okay. And Dr. Nadir, like I've been, by God's grace, I got an opportunity to take part in a couple, 2 to 3 projects which are ongoing. And so I'm happy and I thank you a lot for the opportunity that I received. So can I mention the ongoing projects on my ERAS application as well?
Yes.
Okay.
Yes. So I think there is a limit nowadays on how many research or publication or some in the
Okay.
RISE application, but you put them according to what you think is important. Yes.
Oh, all right, Dr. Nadir. Thank you so much.
You're welcome.
Dr. Nadir, can you also please comment on the personal statement reviews and the application reviews? Because we really are looking forward towards anyone who can, mentor us towards this,
Sure.
and it's getting quite overwhelming.
Yeah. So for the personal statement, there is an app where you can look at previous fellows from this program who applied and successfully accepted to residency or fellowship. So it's available. I can share that link with you guys for the personal statements that they did, and some of them also shared their ERAS application, so you can look at how they did it. But also I'd like to reach out for some of the seniors or some of the graduates. Nowadays we have some batch one and they already finished their residency. Now they are working as attending and so forth. So if any of them is available to help review or assess or help you guys, that might be also an option. So I will try to reach out and let you know.
Thank you so much, Dr. Nadir.
You're welcome.
So I have one question, Dr. Nader, please.
Sure, go ahead, Dr. Rayan.
Okay. I'm gonna ask a question. I know it has been asked many times before, but I just want to know for us, like I'm a Sudanese doctor under the full visa ban and the current situation. So for
Let me stop you.
okay.
This today is a good news. The New York State Court finally rejected the ban that was made by Trump administration against the 75 countries. So there is no more visa ban now.
Oh, I'm coming, Dr. Nader. Dr. Nader, I'm coming.
This is just
Sounds good.
to make sure what it does mean. It means that there is a hope that they could open the visa again, or it's something like bigger than this.
Two things. First of all, I'm not a legal advisor, so if I give you incorrect information, I'm sorry about that. But the first thing is, even when the ban was there, there was approach to excuse medical personnel or professionals from that. That was in the process, and I think it was approved a few weeks ago. But with this one, I think it will remove the ban totally, and I think it's gonna be easier for medical graduates from overseas to apply for visa, and hopefully the programs will not be as hesitant in the past year. Some of the programs were hesitant to interview or offer interviews to applicants from overseas. Hopefully this will not be the case.
This is a very positive information. Thank you so much. It's the best actually news that I have listened to during the previous 1 year. So thank you so much.
Yeah.
You're welcome.
Dr. Rayan, now you should get up and do your best. No any other excuse.
Oh my God, this is very nice actually. That means during the next 2 years we could have the chance to apply, right?
Yeah.
Yes.
Inshallah.
Inshallah.
Thank you so much. Thank you.
You're welcome.
Dr. Nader, I remind that Dr. Elena was joined the CITI course, was text me like she confirmed payment, but unfortunately I think her brother write his email and so on, and like she told me that like this is my email, just send me you can say the link for enrollment and so on to start the course there. Should I share it with you, or can I share with her direct, or what?
Yeah, you can share with her, and if you want to CC me in email or some, yeah, that would be great. Thank you.
Okay, thank you so much.
All right. If no more comments or questions, I'd like to thank you, Dr. Malaz, and thank you all the presenters today, and thank you all who attended today's meeting. Thank you so much for everything, and I'd like to thank you to those who will come and watch the recording in the future. Thank you in advance, and hopefully we'll be in touch next week.
Dr. Nader, just before we can, I have like technical issue with the city. That I have an account before with another institution. It was Weill Cornell at 2016. So since that time, I have an account with the city, and I have some courses there. So should I do like new account with the institution of telegeriatric, or
when you go to your account, when you log in,
okay,
you should go to your name here, welcome Nader, for example, it's gonna welcome Samah or any, and add institutions. So you can add as many institutions affiliation.
As I can. Okay.
Yes.
So
And
I thought
from
that just only any institution had their own. Should I log out from that one or have a new
no, you can
account?
add them as, you can add them as if you are taking classes in different institutions. You don't have to, it's not content in that institutions.
Okay, thank you so much for making it clear for me.
Sure. Again, I'd like to thank you all, and I will see you next week. If you have any questions, please reach out, email or text or call, and we'll be happy to help. Thank you. في أمان الله. السلام عليكم.
Thank you so much, Dr.
Thank you,
Nader.